you guys watch our first video, we really messed that up.
Like the first three videos.
All right. Well, we have a great guest with us today, Dr. CJ Plummer. He is a TBI attending at Vanderbilt, and he is kicking off our doubleheader weekend where we'll be talking about traumatic brain injury. So thank you so much for joining us.
Oh, thank you for having me. I'm super excited. I get pretty excited when we talk anything brain injury. So
yeah,
Awesome.
we are. So we were just kind of discussing before we went live. PM&R is such a small world. There's multiple layers here because CJ went to residency with two of our good friends, Carol, who went to high school with Sheena, and she is attending in San Antonio doing inpatient rehab, and then Christina Wynn and myself have been friends for 11 years. We did our master's together and then medical school. And then she did her she went to PM&R residency with CJ and then did her fellowship in Phoenix at a different program, but with Sheena, it was also in Phoenix. So it's like, all kinds of crossing going on. And then I've had an opportunity to work with CJ here recently through our Black Physiatry Network, and he's going to be our future president. So CJ, tell us a little bit more about yourself. Tell us where you're from and more about your training.
Yeah, absolutely. So kind of going back, Christina and Carol Lee, they both were my upper levels on my first week of rehab as an intern. I did 4 weeks, and it was rough. And they were so gracious and so patient with me. I was fumbling through all of that. But so yeah, they're definitely great friends.
And she says, "Holler, thanks for the shout out. Hey Carol, thanks for watching."
yeah. No, they're my people. So a little bit about me. So CJ Plummer. My family's originally from Jamaica, but family relocated to the Maryland area prior to me being born there. So I'm born in Tacoma Park, Maryland. My father is military. So we moved around quite a bit as a kid. We mostly across the East Coast, North Carolina. We spent a little time. Well, we did go to Germany for a little bit, but North Carolina, Georgia. And so I graduated from high school in Augusta, Georgia. Went to Oakwood University in Huntsville, Alabama, which is about an hour and a half south from where we are now in Nashville. And then after that, graduated there, headed back up to the DC area, George Washington for med school, and finished there, transitioned to Texas for residency at University of Texas. It was University of Texas Health Science Center at the time. Now it's UT Health San Antonio. And so I was there for 4 years and then transitioned over to UW, Seattle, Washington for brain injury fellowship. And now I'm back. I graduated last year from fellowship, and I'm sort of kind of back in this South-ish area here in Nashville at Vanderbilt. So I've been all over.
Yeah.
It's been an interesting ride. We've moved quite a bit in the last couple of years. So
awesome.
That's a little bit of my background.
Great. Dr. Priyanka Shah says hi. I think she's a brain injury doctor as well. So, we have a lot of medical students and even some residents, the majority of our audience here. And, as they know, and some of them may not know, is that you can specialize in different aspects of PM&R. So there's spinal cord injury and traumatic brain injury, neuromuscular medicine are some of the main three kind of neuro focused fellowships. And so why did you choose TBI as your path?
That's a good question. I kind of like to share that brain injury or just the area of brain injury is really what drew me into PM&R. I didn't really know much about this as a field in general in med school. We really didn't have rotations in it or really any exposure to it. But I worked with a pediatric sports medicine physician who was taking care of concussion patients. And I thought it was really interesting how the injuries happen and the sort of the progression afterwards, if you will. And so I was like, well, how can I work with concussion patients? Maybe do sports and then work through concussion. And that led me to sort of exploring the different ways. I saw family medicine. I saw, emergency medicine as a way to get to sports. And I wasn't super excited about any of those fields. They're great fields, but they weren't necessarily for me. And I came across PM&R. So I read a little bit about it, the philosophy of functional recovery, the emphasis on that, sort of the whole picture, holistic approach, multidisciplinary aspects of it. And I was like, oh yeah, I have to look into this. So I ended up doing a rotation. I kind of talked my way into a rotation at National Rehab Hospital in DC, because another rotation fell through at the last minute at my school, and ended up doing some cancer rehab. But then they let me spend some time on the inpatient service. So I saw a little bit of spinal cord injury, had a little bit of exposure to brain injury, and realized, oh, this is definitely what I want to do. It's what I loved about brain injury in particular was the challenge of having to really develop individualized care plans for the specific patients. So you can have brain injury happen to two different individuals and maybe some similarities from an anatomical standpoint, but what they're showing clinically is just so vastly different. And I actually really enjoyed that. So really having to kind of think of tailoring the treatment to specific people as a way to sort of work them through that rehab process. So I loved it. I had some interest in med school with some of the behavioral health side of things as well. I thought about psychiatry at one point, and I saw that I'd be able to do some of that within brain injury as well. And so that was another thing that drew me in. And then also just this idea that we just don't really know everything about the brain. I mean, it's such a complex organ, and you have the injuries that happen, and sort of trying to figure out how to treat them so that they have the best possible recovery is always the challenge, and it's a fun challenge. So I mean, those are probably the biggest reasons why I went into brain injury. I love it.
That's great. So it sounds like you knew you wanted to do brain injury before you even started residency then.
Yeah. I mean, I'd say so. Some formulation of it. I mean, I think initially I was just thinking of concussions because I hadn't really heard any other thing. But and as I learned more and more about it, I mean, I just was like, this is great. I have to.
It is a very rewarding field, that's for sure.
Yeah.
So you had mentioned you did your fellowship in University of Washington. Tell us a little bit about that. And then I'm curious, from fellowship to from being a resident and transitioning to a fellow and attending, just kind of different changes you've gone through. And did you notice anything regionally? Because I know that brain injury can be kind of regionally, like how you learn to treat patients. If you noticed any big difference from going to Texas to Washington.
Yeah, the transition to fellowship was an interesting one. So just to kind of compare and contrast programs a bit, in San Antonio, a good amount of our experiences through the VA as well. And so we're lucky enough to have it be one of the sites for a polytrauma center. So this is a place where you get the full spectrum of care from a brain injury standpoint. You have inpatient beds, outpatient clinics, kind of community reintegration facilities called P-TRIP. And so we really got a lot of exposure, kind of with the full spectrum of brain injury through the VA in residency. And then also kind of the acute side of things at University Hospital, which had our kind of major inpatient experience. So it was really interesting being in that setting and kind of seeing the differences, even within residency, between how we treat these patients in the VA, what type of resources are available, and what aren't, and then comparing and contrasting that to the community hospital that we spent time in. And so, a lot of really interesting differences there. And those differences extended even once I transitioned to UW. So when I got to UW, it's a very well established program, one of the older programs in this country, and very neuro rehab heavy in a lot of ways, even beyond just brain injury. And so it was a wonderful experience for me. I learned quite a bit in that year. Got to work with some amazing people. I'd say some of the differences, it's interesting. The differences that I see from a practicing in brain injury standpoint are really more. Not only is it regional differences, but it's also like hospital system differences. And so, for example, we had back in Texas, there was a unit that had allocated beds that were in a locked part of the unit for brain injury patients. When I got to fellowship training, it was a general rehab floor with brain injury patients, but they didn't necessarily have a separate section blocked off for brain injury patients. So the decisions that you make in terms of management when it comes to like someone at a Rancho 4 level where they're confused and agitated, it changes how you approach things based on based on where you're practicing, what you have available, what that hospital's definition of a restraint is. For example, there's some places that use enclosure beds and others that don't. So it's really it ends up being not only a regional difference, but even within the same city, a hospital or a unit difference. Which, I mean, it adds to to me, it kind of adds to the fun because you really have to get really creative. I mean, you have to be very creative with how you're going to develop a treatment plan to fit that patient. So,
I believe it, for sure.
And so you mentioned, you started as an attending at Vanderbilt, and Vanderbilt finally has their own PM&R program now. I feel like it's long overdue. So tell us a little bit about how it is, working, how it's like working in a new program, and how do you interact with the other fields, in the different departments, and were they receptive to PM&R and what you are able to bring?
Yes, no, it's a good question. So I've transitioned I started here in September of last year. It was a good transition in, but as with any brand new attending, it had a lot of challenges. I'm coming to a new city. I don't know a lot of people, and it's a brand new EMR. At Vanderbilt, the hospital, so the larger system uses Epic, but our rehab hospital uses Cerner. So there was a difference there, and a learning curve there. And of course, the Epic version that they have is not the same Epic version that's in Seattle. And the Cerner that we use is not the same one that you used in med school.
Of course not.
Of course not.
Easy.
So, that would be too easy. Yeah.
Yeah, that made too much sense. So, so that was a huge learning curve in and of itself. I didn't start initially with trainees just to kind of get my bearings a little bit. But once I started with trainees, that was an adjustment as well, because you have to sort of, again, tailor your teaching to the individual. And but I love it. I mean, that's the big reason why I'm here. So that transition, it continues to actually be a pretty steep transition and climb, and I'm learning every day. But I've really enjoyed it so far. And I'm super excited to be here at Vanderbilt. It's a young program. We graduated the first class last year, not this past June, but the last June. And so it's a brand new program. And you were kind of asking about experiences with other services. So my experience thus far has been great. I have been able to spend some time talking with the neurology service, for example, and get quite a decent amount of referrals from them. Looking to maybe do some more in their department in terms of maybe grand rounds and things like that. So that's been good. The ortho department has also been very receptive. I've chatted with several of the sports medicine docs who are taking care of sports-related concussions here as well. We've brainstormed together. The trauma surgery here has also, prior to PM&R getting here, they were really the ones trying to figure out what to do with these brain injury patients. And so it's been really interesting kind of working with them as well and trying to find the common ground in which we can sort of funnel patients where they need to be. So it's been really interesting. And I think for the most part, everyone's been very receptive to PM&R. I haven't had a negative experience in terms of that here. So, which is surprising, something new.
Yeah, I think it's good because I think everyone has heard of it by now. They just don't know exactly what you can do. And when they find out what you can do, they're like, oh my God, like, thank you so much. They're like really receptive to it. And they're like, oh my God.
Receptive. Yeah. And neurosurgery too. I mean, several of the neurosurgeons I frequently message and we go back and forth on things. So yeah, I mean, it's been good. It's been a really good transition so far.
Yeah, and that's a very important relationship to make, because I remember when Sheena and I were in residency, the neurosurgeon used to call our TBI attending all the time, like, hey, I need you to take care of this person. Like, they've been through so much, because it's so, it's always like a tragic story that has happened to the nicest person in the world, right? So they're like, you just try to do everything you can to help them.
Yeah, absolutely.
Yeah, for sure. So tell us more about your practice. Is it all inpatient? Are you doing some outpatient? Are you doing any procedures like baclofen pumps, Botox for spasticity?
Yeah, so I am primarily on the inpatient service. I'm the attending on the brain injury team on the inpatient side. So it's really kind of more acquired brain injury. So I see, mild to severe TBI on that, polytrauma, neuro-onc patients who are like tumor resections. I've had a couple of encephalitis patients. So it's a decent mixture in terms of diagnoses. And then on one half day a week for right now, I'm doing outpatient and looking to expand on that pretty soon. So in that outpatient setting, it's really more tailored to specifically the TBI diagnosis. So kind of, again, mild to severe. Although I do see other things as well. And a lot of it is the community reintegration. I see a lot of post-concussive patients as well who are, still having these symptoms 3 months out from their injury. I also do spasticity as well, mixed in. So I won't say a lot. It's a fair amount of Botox injections primarily. I did receive training in backlift and pump management, but have not established, that hasn't been as established through the PM&R department here. But I do very frequently kind of co-treat with the neurosurgery clinic that runs the pump program here at Vanderbilt. So, I'll see patients very often and say, oh yeah, they definitely would benefit from an up titration on the pump. And I'll just send, I'll send our neurosurgeons a message, and they've been always very receptive to my suggestions. So that's been really good. It's been really nice. Yeah. So that's pretty much most of the practice. Sometimes I'll do some consults if it's needed, depending on who's out and things like that. And I love consults as well. So yeah.
In your program, how many attendings do brain injury?
So let's see. Our inpatient is divided up. There's like SCI, stroke, TBI, general rehab, and our SCI attending, Margaret Jones. She was actually also my attending for a little bit up at UW. She's double boarded in SCI and brain injury, so she does some brain injury as well. Some of the inpatient folks go to her, and she has some in her clinic. Okay. And then we have a peds rehab attending. Her name's Elizabeth Martin. She's also from the Seattle area. It's kind of a common theme. And she also sees a lot of brain injury, pediatric brain injury. So she and I work very closely together. I very routinely will bring kids. We technically don't bring them in younger than 13 to our unit, but I very often have children who have sustained brain injury on my service, and a lot of them I get from the consult service from our rehab doc, or pediatric rehab doc. So.
Okay, yeah. Nice. Sounds like a good group. Yep.
Yeah.
And so you mentioned already, how you didn't start off initially having residents, but now it looks like, they're part of, your service. So what advice would you give to residents who are interested in TBI?
Yeah, I would say look for ways that you can get the experience early to really tease out if it's something you could see yourself doing long term. I would say, other things, even if you develop that interest early, still give it 110% on all your other rotations as well, because there's really the principles that you're learning in residency apply across the board, regardless of I won't say regardless of the diagnosis. You tailor it based on diagnosis, of course, but there are some principles that are going to be there regardless. So, so giving it 110% on any rotation you're on, even if you're not at all interested in it, because all of it will add to your tool belt as you transition into practice. And you're taking care of your brain injury patients. And so I would say that, try to get experience in sort of the full spectrum. Certainly there's some programs that are a little heavier on the inpatient, moderate to severe side, and there are other programs where it's not as much of that and maybe more of the mild TBI side of things, or the concussions, sports or non-sports related. And so if you're able to, trying to maybe get experience in all of the above, and really just to make sure you're building on that experience in the event that wherever you start working, if there's a need that needs to be filled, you can still comfortably do that. So those would be the big things. Network, of course, as well. Ask a lot of questions. PM&R is a very small field, so it shouldn't even be about getting in somewhere, but you should generally try to be nice to as many people as you possibly can. Just as a life principle, because
right. Don't be a jerk.
Be a good person.
Yeah, it sounds basic, but it's
you'll have to say it.
It's not always
sometimes that's hard for people to follow. Yeah,
it is. Yeah, it is. It is, unfortunately. So trying to think about ways that you can, again, make that impression on folks, and really try to be a pleasure to work with at every level, so that you can do that. Trying to think if there's any other major things. Apply early for fellowship. I don't know what last year's cycle looked like in terms of competitiveness, but I know the year I was going through, it seemed like there was a definite uptick in the interest in brain injury. So there were programs saying that they'd never gotten as many applications for fellowship as they had. So apply early and really try to get everything going so that you can just be ahead of that process.
Absolutely. I think for medical students, even residents, I think I already mentioned it's a very rewarding field. I think some of my most memorable patients are patients that I've had on our TBI service, that's for sure. And even if you go and do general physiatry, I do a mix of general physiatry and sports and some spine, but I do consults at a LTAC, which is a long-term acute care hospital. And my partner is brain injury board certified. So I'm often I'm like, Lan, what do I need to order? I'm like, I need how much amantadine? How much amantadine am I doing? How much insulin am I doing? But I had a patient, she was young, she was in her early 40s. She had a really bad, she had an AVM rupture. And before she came to her LTAC, she was on hospice. And she had some kind of trait was bleeding, and they sent her to LTAC to have it traded out. And I'm like, and sometimes, and this is the key of doing a physical exam, because I'm like, I think I was the first person to ever really try to talk to her, because I got in her face and I started talking to her, and I can see her eyes are moving. I'm like, has anyone talked? I'm like, she is in here. I know she understands everything I'm saying. So, we started some neurostim on her, and I'm telling you, she woke up. I sent her to BIR in Dallas. She was doing some walking. Dr. DeVille, who was my attending, FaceTimed me here recently, and I was like, I had tears. Oh my God. Yeah, so just really, like CJ was saying, one general principle you can always take away is always be nice and do a good physical exam on patients, because they will tell you what's wrong if you take the time to listen, and if they can't talk, do a good physical exam, and that will help you with everything. That's just my 2 cents.
That's so true. I mean, so I do mostly spine, right? And you may think, when would you ever need to fall back on your TBI knowledge? But so even like with mild concussion, so I had a patient, young girl, she was involved in a horrific accident, and I was just seeing her for some back and neck pain after her MVA, and just talking to her. She's a college student. Just was saying that she's having trouble concentrating. She had this period of loss of consciousness, and like no one had worked her up, for TBI. So don't forget that we are physiatrists first, right? No matter what specialty we go into or subspecialty we go into, don't forget your roots. And we go into the specialty because we love to take care of patients. We love function, quality of life. So you'll see patients that have kind of fallen through the cracks, even who had spinal cord injuries, and
today,
no one has, they don't have a
I had
PR
one.
Yeah.
Today I had one. I am on call for consult. So I had a patient that was admitted for CHF exacerbation. She's been falling since November. And I go in and I'm talking to her. She's like, yeah. She's like, my right leg feels weak. I feel like a dead leg. I'm like, well, that's weird. You're pretty young. So I do exam. And I'm like, did anyone realize that she can't lift her leg up? I'm like, an order MRI. No one's ordered an MRI in almost a year for that.
Stuff be fine. It's
Yeah, it's crazy. Like she's gonna have back surgery.
Yep.
And she had tears in her eyes. She was crying. She was like, "Do you see someone's gonna help me walk better?" And she was like, "Oh my God, thank you so much." So do a physical exam. We're physiatry first. But,
Absolutely.
It's
so important.
Yeah, we do have some questions from the audience. First of all, Noel, he says, "Hi, Dr. Plummer. Thanks for introducing me to the group."
Oh, nice. Yes. Good guy.
And then he says, actually, the other group. So I don't know what other group he's talking about.
Is he talking about our Physiatry Network?
Yeah. Yep, that's what it is.
You're welcome. You're welcome to that group.
Yeah.
And then Priyanka says, I recently completed my brain injury fellowship and I'm starting as attending in October. What tips do you have for a new brain injury attending? What are some of your biggest challenges? That's an excellent question. And congratulations on finishing.
Congratulations.
Yes, congratulations. We need as many brain injury providers as possible. So congratulations. That's a really good question. I mean, I think advice for a new attending, and just in general, as you start that new role, take time to, let me back up. As you start that new role, you will be tempted to identify all of the issues that are present wherever you're practicing. You'll identify them pretty quickly. And you may already know some of them based on who you've talked to in your department. You coming right out of this fellowship training, you have all of this knowledge, all of this expertise, all of these great experiences. And it's very tempting to start and to just want to just take over everything, you're the specialist on the subject matter. So you go in and you identify what needs to be happening differently, and you want to just take over. And my advice would be to just slow down and take time to understand where you're going to be, the personnel that are there, the personalities, the historical context behind maybe why we are where we are, in the unit, why the unit does things a certain way. Just take a lot of time listening first, would be my biggest piece of advice. That way you really are then able to take the time to learn the team, to learn the individuals, to learn the environment, so that as you're providing feedback and ways of doing things differently or better, it's received more, as opposed to kind of going in as this new attending and just wanting to just show everybody how much you know, and you're just going to run over whoever you need to do it. I would not suggest that be the approach at all. So that's actually probably one of the biggest pieces of advice I'd have. Understand that even with all of that fellowship training and expertise, there's still no way to know everything about brain injury, really about anything. There's no way to know everything about everything. So be patient with yourself and be okay with asking questions. Be okay with reaching back out to your former attendings to ask clinical questions on things that you don't know or you're not comfortable with. Be okay with the fact that maybe there's some parts of brain injury you still haven't experienced, even with all the extra training. And that's where it becomes that concept maybe some of you heard about a lot, which is just being a life learner, and making sure that you are challenging yourself just on a daily basis to learn something new, to read about your patients, to read about the diagnoses and ways of treatment, those types of things. So that I would say those are probably the two biggest ones. Be nice to everyone. I can't emphasize that enough. As simple as it sounds.
Because PM&R is a very small field. Be nice, because if you don't, it's going to come back.
Nice to everyone. Try to make sure you're having constructive conversation, regardless, whatever it is. Just be constructive in everything that you're doing, and yeah, I mean, I'd say wellness. So just making sure that you're taking time to recharge. It's gonna be a big change being an attending. It's just a totally different experience, and so be patient with yourself as you're making that transition. You'll make mistakes, we all do, but just learn from them and kind of keep things moving.
And I think you already kind of gave some good advice about how it might be different from where you were in fellowship. Like you might be at a blocked unit and have enclosure beds. And I think when you start a new program, just definitely know that it might not be exactly how fellowship was, but that's okay because you can make it your own.
Exactly. I mean, it's every place I've been has been so incredibly different. I mean, the ways that I'm practicing brain injury here are very different from how I practiced it as a fellow. And it's very different from how I practiced it as a resident, just because, again, like there's just so many differences. This, for example, this hospital I'm currently at, Vanderbilt Stallworth Rehab Hospital, it's a freestanding rehab hospital. So we aren't physically attached to the medical center. And that changes the way that you triage issues as they come up. I mean, that changes the way that you're approaching things clinically. It's not as simple as just getting a stat CT head, putting the order in, pushing the button, and then it happening. There's a little more to it than that. When you're at a freestanding rehab hospital versus somewhere that's within the actual hospital itself. So just understanding those things and just adjusting your practice however you need to.
Great advice. All right, so Noel says, military medicine uses the NSI, Neurobehavioral Symptom Inventory. He's asking if that's an effective questionnaire, or is there a more effective questionnaire that you use for patient follow-ups?
Yeah, I think some of it depends on what they're using it for. I mean, I don't use the NSI as often. I'm familiar with it. I don't use it as often, but it sort of just depends on what you're scaling out or what you're trending out. But I am a huge proponent of the outcome measures that we do have and trying to figure out some way of keeping track of symptom reporting. And so it really sort of depends on what I'm doing. I mean, am I looking, I'll use different screening measures for different mood disorders. So, maybe a basic PHQ-9 for depression or GAD-7 for anxiety, just to kind of get a sense. Certainly none of these are perfect. So they're not the all in all by any stretch of the imagination, but, versus for my post-concussive, maybe I'm using more of the symptom scale. It just sort of depends, or that symptom checklist, I should say. It sort of just depends on what I'm tracking, and I'll adjust it accordingly. When I'm checking people in clinic cognitively and meeting them for the first time, sometimes I'm going through a MOCA with them to just get a sense. And of course, again, there are pros and cons to using the MOCA. in this population, but you're generally just trying to use it to get a general sense of what's going on, and so that you can test your intervention later and see if there's any improvement. So that's generally how I think about that. And I do the same thing on the inpatient service. I mean, I use the agitated behavior scale to track and trend agitation, and to try to really get a sense of what specific thing is being classified and being described, and what intervention is working or not, or like, are we going up on our ABS scores as opposed to the opposite direction? So it's I really try to tailor it based on what the specific issue is and kind of go from there.
Sorry, I had to take that phone call, you guys. I'm on call, so I was not trying to be rude. It was the hospital having to call me. No, I think that is excellent advice. It's very much kind of trial and error, right? You're like, okay, we're gonna try this, see how it goes, and okay, come back, we'll go for it. So
exactly,
it'll be different for each patient. Like how you were saying, right? That's the fun thing I think about TBI.
Yeah, everything, it really is so different.
Everyone's recovery and progress is totally different.
Yeah, it's amazing when you have a patient that's not talking and then you just start and you walk in the next day, you're like, oh my God, they can talk. It's like almost like watching a baby, like you walk again, talk again, and you're like, yes.
It's super rewarding, and it's fun working with trainees and having the trainees see that and experience it too. We've had a couple of those cases in the last couple of months where they came in and it was just not looking good. But we were able to kind of help out with a couple of things, try several different things, try to optimize their environment as much as possible to promote their recovery. And within weeks, they're walking around, they're joking with you. I'm joking with them. I had one patient here locally in particular. He was in a car accident, really severe TBI, right hemiplegia for a while. I mean, just a lot going on. And by the end of his stay, he's walking down the hall, like he's walking out of the building, and we're all just elated for him in his recovery. He actually is he's a local rapper, and we were joking like, you're gonna have to come back to clinic, and I need a whole verse dedicated.
Right. I need you to be in the video.
A whole verse dedicated to me, and the therapist wanted a chorus dedicated to me. It was a good time.
Right. That's so funny. That's good. If you guys have any more questions, please ask. Priyanka Shaw says, thank you, great advice. And Noel says, gracias. They're very appreciative to your advice. We'll see if anyone types anything, but in the meantime, we ask every person we have on our show, if you were not a PM&R doctor, what would you be? And you can tell us medicine, like if you would have chosen another field, and if you would have chose just something else, non-medical.
Yeah. Oh man. Yeah. So, this is a difficult question for me because when I was a kid, I wanted to be everything. So like, I wanted to be a doctor. I wanted to be a FBI agent. I wanted to play in the NBA, and I wanted to be a teacher. Like I wanted to be all of those things at the same time. And so, I don't know that much has changed. I mean, I probably am still that all over the place. I mean, I think if I weren't doing medicine, I would still want to do something that would let me teach. So, there was a time period in my life where I thought about doing, being like an elementary school teacher, because I think kids are fun, especially in that age group. So that was something that I thought about. It would have been something in education, likely. Honestly, that's probably what I would have done.
I think you'd be such a fun teacher.
I appreciate that. I'm trying to think of other fields of medicine. I mean, I considered psychiatry, but I kind of liked. I liked everything about psychiatry, but I sort of liked some of the things that psychiatry doesn't focus as much on too. So I wanted sort of a little bit more of sort of the behavioral stuff on top of, some of that, kind of like internal medicine side of things too. You
Mhm.
know, I wanted that kind of mixture.
I tell people that PM&R doctors typically liked their psych rotation in medical school. Don't you think? Because it's like you have a little bit of, there's some psych kids there. Well, it's applicable to almost every field of medicine. So,
Right.
no, that's cool. Noel does have another question. He says, any suggested dietary/nutrition changes or additions to help with post-TBI?
Yeah. So the short answer is there really hasn't been any specific type of diet that has been, from a consensus standpoint, there is no real consensus guidelines or clinical practice guidelines, to my knowledge, that are consistently in favor of one diet versus another. You know, when you start thinking about the recovery process, what is more important than anything is making sure they're getting some kind of nutritional supplementation as early as possible after their injury. I think there have been some studies that have looked at that in terms of being one of the ways to promote good functional recovery. So I think that's probably more important than even the specific diet. I know it's not really answering the question, but I just haven't seen any, to my knowledge, there hasn't really been any consensus on a particular diet that is just so much more beneficial than another in the brain injury recovery process. Excuse me, the brain injury recovery process. I mean, you look at like some of the things we deal with as secondary issues in brain injury, like post-traumatic seizures, for example. Mm-hmm. The epilepsy literature talks about ketogenic diet as a way to kind of help combat refractory epilepsy and things like that. But again, I don't know that, at least from, again, to my knowledge, any suggestion that also just spills over to brain injury as a whole, and I don't know that we've gotten there yet. But good question.
No, I know for concussions they are looking at omega fatty acids. Well, yeah. I know when I was in TCU that every concussion we would put them titrate them on omega fat. They would hate it. We said, like, go ahead and take 2 shots of those omega fatty acids every day. But yeah. I know.
Yeah, the omega-3s, the literature is a little mixed on them.
Right.
And, they're not completely, at least orally, they're not completely benign. I mean, there can be lots of issues with GI, like just upset stomach, those types of things. Horrible. But I mean, I've definitely, I remember one in particular as a medical student. There was a kid who was unfortunately hit by a car, and we were consulted on him, and he just wasn't really progressing. And the family swore by the omega-3. Like, you're just kind of seeing what else could be tried. And whether it could have just been that the takeoff in terms of his recovery happened just as we were starting the omega-3. But yeah, he had a pretty significant recovery in the couple of weeks that I saw him, just being on omega-3. So that's anecdotal. I mean, again, the research is kind of mixed. The results are sort of mixed on it, but yeah.
It's like a hyperbaric, the hyperbaric chambers also. That's another controversial.
Yeah,
that one's
essential oil.
Essential oil.
I had a patient's family that swore, like, you would walk onto the floor and it was like a spa. They're like,
it smells good.
It smells real good. Yeah. The hyperbaric is very controversial. So.
Mm-hmm. Yeah, Noel was saying, sometimes he's heard like glutamine, zinc, vitamin D. I actually did my senior project on vitamin D in traumatic brain injury.
I remember that presentation.
It's been published in a journal. I'll let you know on IG tomorrow which one.
Dr. Verman, Angela says hi. She is the spinal cord injury attending at San Antonio. So she was our senior.
She was our senior. Yes, hey Angela.
Oh, very nice, very nice.
All right, guys. Well, great questions.
Great talk, guys.
Yep. Dr. CJ Plummer, we really thank you so much. I think you dropped a really nice, a lot of gems, and we really appreciate what you do for your patients. I know it's sometimes a very tough population to work with, so I'm glad you're out there.
Yes, yeah, no, I appreciate you all having me. This is great. I can come back anytime if you want.
Yes,
Yeah,
we will have you
definitely
back
would.
on. It'll be fun.
So tomorrow is our part 2 from our TBI weekend. So we will have a brand new TBI fellow. She just started, Dr. Maria Paula Frone, and then Dr. Mary Beth Miller Phillips, who is attending at Baylor in Dallas, and she actually is the program director at the program there. So it's a brand new program. So we'll kind of get their insights on what it's like to be a new fellow and a new program director. So
awesome. Thanks, guys. Everyone have a wonderful evening.
Yes.
Bye.
Everyone
I